السلام عليكم أعزائي الطلبة. Our lecture today is about chronic venous insufficiency. What is chronic venous insufficiency? Chronic venous insufficiency, or CVI, is a spectrum of clinical manifestations occurring due to chronic venous hypertension in the lower limbs, which follows the development of valvular incompetence, reflux, and or venous obstruction. So, the secret behind CVI is chronic venous hypertension in the lower extremities, whether in the superficial venous system or in the deep venous system, or sometimes in both. Now, prevalence of CVI. Actually, CVI is a really common problem worldwide. It is 2 times more prevalent than coronary artery disease and 5 times more prevalent than peripheral arterial disease. So imagine how common this condition is. Now, pathogenesis of CVI. CVI develops when venous pressure is increased in the lower extremities, of course, and return of blood is impaired through several mechanisms. First, venous valvular incompetence in the deep, superficial, or perforator veins. Second, venous obstruction. That to say, obstruction in the deep venous system, for example, DVT. Third, dysfunction of the muscle pumps leads to venous blood not being effectively emptied out of the distal extremity, for example, immobility. So, all these 3 mechanisms can lead to venous hypertension in the legs. This venous hypertension will lead to CVI. So, 3 important mechanisms behind the development of chronic venous hypertension: valvular incompetence in the deep or superficial system or both, venous outflow obstruction like DVT, and muscle pump failure. All these 3 mechanisms will lead to venous hypertension and eventually CVI. Now, still in the pathogenesis of CVI, how this chronic venous hypertension will lead to the skin manifestations of CVI, like pigmentation and ulceration. Through 2 theories, or there are 2 theories that by which venous hypertension will lead to skin changes. First theory is fibrin cuff theory, in which there is dilatation of capillary beds and fibrinogen leak. This will lead to formation of a fibrin cuff. This will stop delivery of oxygen and nutrients and growth factors to the skin and subcutaneous tissue. Another theory is called white BC entrapment theory. White BC trapped in the capillary wall, an inflammatory reaction with release of proteolytic enzymes and endothelial damage. Both these theory will lead to skin manifestations of CVI. Okay? Because venous hypertension, through these theories, will lead to defective microcirculation in the skin and subcutaneous tissue. And then skin changes will develop. Defective microcirculation due to venous hypertension, chronic, will lead to RBC lysis, hemosiderin deposition, dermatitis, lipodermatitis, and finally venous ulcer. So, to repeat, chronic venous hypertension through these two theories will lead to defective microcirculation in the skin and subcutaneous tissue. This defect in microcirculation will lead to RBC lysis, hemosiderin deposition, and finally skin changes of CVI will develop. Now, classification of a chronic venous insufficiency. As I said in the previous lecture of varicose veins, CF classification is the universal classification used to classify venous disorders in general, whether varicose veins or CVI. Clinical, etiological, anatomical, and pathophysiological classification. And as I said before, we have to focus on clinical classification because it is widely used in clinical practice. Now, focus on C3 to 6, starting from edema, ending into active non-healed ulcer. So these are the skin changes in CVI, starting from grade 3 to grade 6, where increased pain, reduced quality of life will appear. Okay? Now, what are the risk factors of CVI? If you look here, the risk factors of CVI are greatly similar to risk factors of varicose veins, like increasing age, family history, prolonged sitting or standing, increased body mass index, smoking, sedentary lifestyle, trauma, previous DVT, AV fistula, high estrogen states, and pregnancy. So these factors are similar to risk factors of varicose veins. Now, what are the clinical symptoms of CVI? First, pain, heavy legs, cramps at night, paresthesia or burning sensation, localized itch with skin changes, of course, edema. These symptoms worsen with standing or walking and are relieved with rest and elevation. These are the main clinical symptoms of CVI. Now, what are the clinical signs of CVI? First clinical sign is leg edema. Second, skin changes of CVI. First, hyperpigmentation of the skin of legs. As I said before, due to hemosiderin deposition, due to RBC breakdown. Second, stasis dermatitis. Third, lipodermatosclerosis, as I said, chronic fibrosis and induration of the skin of legs. Venous stasis ulcer, and sometimes you see inverted champagne bottle appearance like this with a chronic CVI, or Talib's equinovirus, which is a progressive scarring and around the ulcer lead to permanent deformity. As I said before, it is a rare complication and very advanced complication of CVI. Now, what are the investigations used in cases of CVI? We have non-invasive investigations, which are first duplex scan, or what is called Doppler ultrasound. As I said before, this test is commonly used in clinical practice and very effective test. It can evaluate for deep and superficial venous thrombosis, and it also can evaluate for incompetent veins with significant reflux disease, and it can evaluate for incompetent perforating veins and tributaries. So by this duplex scan, we can assess both the superficial and deep systems in regard to valvular incompetence and patency. Also, we can use CTV or MRV, especially in the assessment of deep venous system patency. Also, we can use invasive investigations like venography or IVUS, intravascular ultrasound. Now, what is the treatment of CVI? First, we have conservative treatments. Leg elevation, heart level for 30 minutes, 3 to 4 times daily. This leg elevation will improve microcirculation and it reduces edema and promotes healing of venous ulcer. Second, exercise, daily walking and simple ankle flexion exercises. Also, we have compression therapy, as I mentioned in the lecture of varicose veins. But compression therapy should be avoided when there is cellulitis or significant arterial occlusive disease. If the patient with CVI has severe cellulitis and inflammation, or he has peripheral arterial disease in association with CVI, compression therapy is contraindicated. Remember this, please. Now, regarding compression therapy, we have compression bandages, elastic or non-elastic, single or multiple layers. So, compression bandages. Or we have compression stockings, what is called graded compression or graded decompression. As you see here, pressure is reduced while we ascend from the ankle to the thigh. This will enhance venous emptying and reduce edema. Now, we have local treatment because, as I said before, we have a lot of skin manifestations in CVI. So local treatment, first skin care by using skin cleaning agent or wash with a mild non-soap cleaner, or we use some emollients that provide a film of oil to lubricate the skin, or we use some barrier preparations which physically block chemical irritants and cause moisture, like zinc oxide or Vaseline. Or sometimes we can use topical corticosteroids to treat skin dermatitis. Also, we have ulcer care. We will talk about ulcer care in the section of venous ulcer. Now, systemic therapy also can be used in CVI, like venotonic drugs, which increase the venous tone in the veins and enhance venous outflow. Also, we can use vasoactive drugs like Brintal. This will improve red cell deformability and prevents inappropriate white cell activation and enhances fibrinolysis. Aspirin can be used, which may accelerate the healing of a chronic ulcer. Now, the second line of management of CVI is ablation therapy. Ablation therapy used in patients with persistent signs and symptoms of venous disease after a minimum of 3 months of medical therapy, and in patients with documented reflux. Okay? Absolute contraindications for thermal therapy: acute DVT, phlebitis, and pregnancy. Please notice here, ablation therapy, by which I mean either surgical ablation or endovenous, like laser or radiofrequency. Okay, so we have surgical ablation and endovascular or endovenous ablation therapy. So this ablation therapy is mainly used in cases of superficial chronic venous insufficiency, superficial CVI. That to say, due to varicose veins with or without incompetent perforators. For deep venous insufficiency, we have another approach. Okay? Now, as I said, ablation thermal therapy, either by endovenous laser therapy or endovenous radiofrequency, as you see here. Now, surgical treatment or surgical ablation, as I said before, it is the same procedure used in the treatment of varicose veins, by which we physically destroy the vein and with its partial or complete removal. So we either use high ligation and stripping with or without phlebectomies. Now, what about deep CVI treatment? Look here, for superficial venous insufficiency, like varicose veins, as a cause of CVI, we use either surgical or laser or radio frequency. But if the cause of CVI is mainly in the deep system, in the deep veins, what would be the line of treatment? Now, look here. If the cause in the deep system is deep reflex, that to say, defective valves in the deep venous system, we use a procedure called valve reconstruction. Or if the cause of CVI in the deep veins is chronic deep venous obstruction, like chronic DVT, we can use venous stenting. Of course, in both these two conditions, we need venography. Venography is needed and it should be considered in cases of deep chronic venous insufficiency. Okay? And finally, how to prevent chronic venous insufficiency development? First, adequate anticoagulation after DVT. Second, use of compression stocking for up to 2 years after DVT or venous trauma. Third, lifestyle changes, for example, weight loss, regular exercise, reduction of dietary and ACL. So that's all about chronic venous insufficiency in general. Now we will talk about venous ulcer. Venous ulcer is the most important clinical manifestation of CVI. What is an ulcer? In general, an ulcer is a break in the continuity of an epithelial surface, as you know, characterized by progressive destruction of the surface epithelium and granulating base. So, venous ulcer is a skin ulcer caused by venous hypertension. Let's say high venous pressure. Causes of leg ulcers in general, as I said, venous hypertension, peripheral arterial disease, what we call ischemic ulcer, diabetes, neuropathic ulcer, trauma, malignant or malignant ulcer, infection, and vasculitis. These are the main causes of leg ulcers in general. Now, what are the clinical features of venous ulcer? First of all, inspection. The common site of venous ulcer is in the medial aspect of the lower leg, what's called gaiter area. It is solitary. It is usually oval in shape. The edge is sloping with surrounded pigmented skin and sometimes associated varicose veins. Regarding palpation, tenderness, it is fixed to underlying skin, and with palpation sometimes we need to test for venous incompetence, to test for local lymph nodes, and sometimes bony deformities are evident due to abnormal gait. What investigations used in cases of venous ulcer? They are more or less similar to investigations used in CVI, because venous ulcer is a clinical manifestation of CVI. So we have non-invasive, as I said before, duplex scan, CTV, or MRV. Invasive, like as I said, venography or EVAS. Another investigation sometimes needed in cases of venous ulcer, like skin biopsy, if we suspect malignancy, especially in chronic ulceration. And sometimes we may need to assess for arterial disease by doing either ankle brachial pressure index or arterial Doppler or arteriography. Now, very important to differentiate between venous and arterial ulcer in the lower extremity. So when you see an ulcer, please ask yourself, is it venous or arterial? Now, regarding the site, arterial ulcers usually occur either in toes, foot, or ankle, while venous in the gaiter area. Edge. The arterial ulcer punched out and well defined, the venous sloping and gradual. Wound bed appearance. Arterial covered with slough and necrotic tissue. Venous also covered with slough. The size of arterial ulcer is small, as you see here. The size of venous ulcer is large. Exudate level in the arterial ulcer is low, high in the venous ulcer. Pain. Arterial, of course, it's associated with severe pain because of ischemia. Pain in the venous ulcer is minimal, but sometimes in chronic advanced cases, the pain may be severe. Also, venous ulcer is associated with skin pigmentation and varicose veins. Arterial ulcer also is associated with negative distal pulses. Now, treatment of venous ulcer. Treatment of venous ulcer. First, treatment of CVI in general, as I mentioned in a moment in this lecture, and in addition to standard ulcer treatment. So, starting with conservative, like leg elevation, passive movement, active movement of calf muscles, and use of high-level compression, either compression stocking or bandaging, as I said, a gradual decompression or graded decompressive elastic stocking. And we can use different surgical and endovenous treatment modalities mentioned in varicose veins and CVI. I will summarize in this figure. So, if the cause of venous ulcer, that to say CVI, is superficial veins, we use either laser therapy or radiofrequency therapy, or we can use surgical ligation and stripping, or we can use sclerotherapy. So if the cause in the superficial system we can use these surgical and endovenous modalities or sclerotherapy to treat the superficial venous system as a cause of CVI and venous ulcer. If the problem is in the perforators, we can use either endoscopic ligation or endovenous ablation of perforators, or we can use surgical ablation of the perforators. If the problem in the deep veins, so that to say there is deep venous obstruction or valvular incompetence that cause the CVI and hence venous ulcer, we can use either deep vein bypass or valvoplasty or valve transplant. This is the summary of surgical and endovenous treatment modalities used in the treatment of venous ulcer. We have standard ulcer management. So this ulcer needs a special care and maybe for a long period. First, cleansing and debridement. Any dead tissue, any necrotic tissue, any devitalized tissue should be removed either surgically, what we call surgical debridement, or by using some topical agents or called enzymatic agents that used to break down and separate the necrotic tissues from the ulcer bed. Also, we need to use dressing and topical therapies like zinc-based bandage, what we call Unaput. So either surgical debridement or enzymatic debridement with dressing and topical therapies. Now, other modalities used in the local standard ulcer management is skin and substitutes. We can use either skin graft, split skin graft, punch graft, or we can use allogenic grafts. What about antibiotics, whether topical or systemic? Antibiotics in cases of venous ulcer are used if there is surrounding inflammation, if there is increased pain, if there is heavy or purulent exudate, or if there is rapid deterioration of ulcer, or if the patient has fever. Systemic therapy also can be used in the treatment, as I said, like systemic antibiotics, aspirin, Daflon, or Trental, as I said in a moment in CVI. That's all about venous ulcer and CVI. Thank you very much. And our next lecture will be about AAA, abdominal aortic aneurysm. Thank you.